дентални медици. Успех и професор Влахова може да продължи с днешната сесия.
Okay, dear colleagues, I would like to welcome Vasil Dimitrov with the presentation Selective Laser Melting in CAD/CAM Dentistry. You're welcome. You may share the screen of your computer.
Yes. Hello, ladies and gentlemen. Do you see my screen now?
Yes, we can.
Yes, we see.
Okay, so I can start. The topic of our issue is selective laser melting in CAD/CAM dentistry, made by me and Jordan Vasilev. We are dental students in the Medical University of Plovdiv, with the help of Dr. Tomova and Professor Vlachova from the Department of Prosthetic Dental Medicine. So, what is selective laser melting? It is a specific 3D printing technique used in contemporary CAD/CAM dentistry, a computer-aided design and computer-aided manufacturing, which is more and more based on digitalization. So the process of making dental restorations by sintering alloys basically includes 3 steps. First, it is taking a 3D digital impression with an intraoral scanner directly into the patient's mouth. The second one is designing a virtual restoration, a 3D CAD model with a commercial computer 3D package software. The virtual restoration file then is sent directly to the SLM printing device to create a metal framework of dental restoration. The principle of SLM process starts with building a platform applied with very thin layers of metallic powders, which are completely melted later by the thermal energy induced by one or several laser beams. The cross-section area of the designed 3D part is built by selectively melted and resolidified metallic powders in each layer. The building platform is then lowered by a small distance, and a new layer of metallic powder is deposited and leveled by a recoulter. The laser beams can be directed and focused through a computer-generated pattern by carefully designed scanner optics. Therefore, the powder particles can be selectively melted in the powder bed and form the shape of a 3D object according to the CAD design. This study is focused mainly on cobalt chrome dental alloys because they are one of the most commonly used alloys in contemporary dentistry. The aim of this study is to review the advantages and disadvantages of cobalt chrome dental restorations produced by selective laser melting, to evaluate their quality, and to compare SLM-made restorations with conventionally fabricated ones, including casting technique and milling technique. A computerized database search was conducted using the following research online databases, as the main one was Dentistry and Oral Sciences Source, which provided a total amount of 41 scientific papers using these keywords in the time restriction the last 15 years. 34 articles were used for the purpose of this study. So, what are the characteristics of an SLM-made dental restoration? It shows a more homogeneous microstructure, which is lamellar in nature and consists of 2 dominant faces, the epsilon face, which is face-centered cubic face, and the hexagonal closed pack face, which is gamma face. Important fact is that no intermetallic face was revealed. For comparison, casted restorations have less bulky and dendritic-like microstructure with a dispersed, heavier intermetallic face. Porosity basically is the presence of pores or small holes in a structure. It is undesirable as it causes the mechanical properties to deteriorate and increases susceptibility to corrosion. SLM-made restorations theoretically have almost 100% nominal density. The mechanical properties of cobalt chrome alloys depend on the microstructure, its morphology, and composition. As we can see in this table provided by Toilomet et al., The SLM prepared specimens show increase in yield strength and tensile strength, and the values for hardness and stiffness are almost 2 times higher compared with the casted and the mild specimens. Higher hardness and more homogeneous microstructure result in increased corrosion and wear resistance. It has a lot brittleness and a less liquidity. During the selective laser melt process, the last fused top layer shrinks upon cooling with a magnitude dependent on the underlying and solidified material, and between layers, a large residual stresses accumulate, resulting in distortion of the product. This problem is partially solved with heat treatment, which is heating the alloy to high temperatures for a certain period of time. Researchers proved that heat treatment relieves the residual stress, eliminates the crystal defects, and stabilizes the microstructure. Relevant data found in the literature indicate that the average surface roughness immediately after sintering is about 8 micrometers average. After sandblasting with aluminum oxide, the roughness is reduced due to surface homogenization and uniformization. The roughness of the sintered cobalt chrome alloy could be a problem when creating a removable dental restoration, but on the other hand, it could be advantage because it enhances the bond between the metal and the ceramics. Fitting accuracy of SLM made restorations is excellent, and compared to the conventional techniques, it is superior to casting and poorer to milling. In conclusion, the main advantages of the selective laser melting technique are time and cost saving, homogeneous metal structure, good marginal fitting accuracy, and eco-friendly technology. The main disadvantages are hardness, stiffness, the presence of residual stresses. A contradictory results from different author teams comment where the corrosion resistance is increased or it is decreased, and further clinical studies are needed to increase the acceptance of this technology by the worldwide dental community. Thank you for your attention.
Thank you to our student Vasil Dimitrov. Very nice presentation. I would like to say that the students, they made almost everything by themselves, students that were participating in this study. And I would like to give all of the participants in this session ability to ask questions, please. Okay, dear colleagues, do you have any questions?
This technology, do you reckon it can be used in the near future, in the next 50 years, or is it something further on?
This technology needs a big investment because it is expensive, and a large dental laboratories are using it, but smaller dental technicians don't use it. But with the years, I believe it will be improvement in the SLM devices. They will be smaller, cheaper, and more dental technicians are going to use them. So yeah, it is already used, but it's not so common, but there will be progression in the using of the selective laser melting technique, I believe. Yes.
Okay, thank you.
Okay, thank you very much about the question. This is not the future, this is the reality, and we have this technology in our CAD/CAM center in the Faculty of Dental Medicine. Another questions? Okay, if there are no additional questions, I would like to thanks to Vasil Dimitrov for the nice presentation, and to give the word to the director of the CAD/CAM Center in the Faculty of Dental Medicine, Dr. Stefan Zlatev. You're welcome.
Hello, colleagues. So, dear Chairman, dear organizational committee, and dear colleagues, can you see my screen?
Yes, Dr. Zlatev, we can.
Okay, thank you. So I'll proceed. The topic of my presentation is difference in preparation surface area, endocrown versus classical crown. And this presentation was designed as a rapid communication. So a couple of things to start with. Endocrown is a type of design that was that we, our research team, investigated for about 10 years now. And what we found out in a previously held survey was that almost 95% of our colleagues in Bulgaria do not know what an endocrown is. Hence, what is an endocrown? So this is a monolithic adhesive restoration with a supragingival preparation margin, and the endocrown uses a probe chamber for accessory retention without entering the root canal system. And as you can see on your screens on the bottom right-hand side, you can see manufactured endocrown with its specific preparation features. If you look at the lower left corner of the screen, you can see the number of publications per year containing endocrown and endo-dash crown as keywords, which I have extracted from one of the largest databases, PubMed. So as you can see, there is a trend towards an increased interest by the community, and hence the subject is important, as well as the different properties of this type of preparation design. So why are we interested in surface preparation area? Well, one of the two major components which ensure longevity and success of indirect restorations are the surface area, and which is directly connected to retention, and the type of the preparation, or a retentive form of the preparation. So what we did in this study was we used standard normal typodont Frasacco type A3 lower right first molar that we prepared in a specific way. We used VPrep technique, which is a minimally invasive technique, which was introduced around 15 years ago with a specific burst set, NTI 7020. With specific preparation features, which you can see on the right side of your screens. So the width of our preparation junctions was designed at 0.8 millimeters. The occlusal reduction of our preparation was equal or more than 1.5 millimeters, whereas the height of the axial walls was designed at an equal or more than 3 millimeters. And this was the design for the full coverage or classical crown preparation. So when we prepared the tooth, an intraoral scanner Trios 3Shape was used to digitize the preparation. The same preparation was modified later on by making an accessory retention in the pool chamber with an average depth of 2 millimeters, and we attempted to maintain the residual dentine walls of equal or more than 1.5 millimeters. Both scans of the classical preparation design and the modified endocrown design were exported as STL files and later on subsequently imported in Blender, which is a software environment for 3D modeling. An add-on Neuromorph was used to calculate the surface of this geometrically irregular object. And our results indicated that the classical full coverage ground design had 144.76 millimeters of surface area, whereas the endoground design showed a higher surface area of 161.79 millimeters. The percent difference between the two designs was 11.11. Which is comparable to a 9-degree change in the total occlusal convergence angle, as reported by different authors in molar preparations. So, since this is a new methodology, every new method requires a validation procedure, and in order to do validation regarding the method, we use software-generated simple geometric shapes that you can see on the left corner of the screen. So we use the sphere. So we used a sphere, a cube, a cone, and a cylinder. Now, as you can see, I've placed the values here towards the center of the screen, and what we can see is that there is some difference between the mathematical formulas for calculating surface area and actually software produced values, with the software values being a bit smaller than the mathematically produced values for surface area, with the only equal numbers in the cube design. So this difference is due to the nature of the STL file and the way that the mesh is created. Basically, as you can see, the description of a physical object is smaller than its real than the real physical replica. For our study, we found that the accuracy is sufficient, with the difference between the physical replica and the STL model within the micrometers range. So, in conclusion, the increased adhesive area in the endochrom preparation design, which I attempted to communicate in the study, might explain the comparable and better results for these types of constructions, which are reported in the literature in comparison to the classical full coverage crowns. And thank you for your attention.
Thank you very much, Dr. Zlatev. I would like to give you ability to ask questions. You're welcome, colleagues. Any questions or no questions? Dr. Zlatev and Dr. Hachigayev are working in this field from a few years, and I hope soon this investigation will finish with the PhD thesis of Dr. Hachigayev. Okay, if we have no questions, thank you very much, Dr. Zlatev, and I would like to give the word to Desislava Georgieva for the presentation, two-zone in vitro study of root temperature changes during intracanal cryotherapy in an extracted human tooth. You're welcome.
Hello, everyone. Can you see the presentation?
Yes, we can.
Uh, in this topic, I was supervised by Marieta Tudorova, Plamena Zagorchev, and Silvia Dimitrova, and the topic is in vitro study of root temperature changes during cryotherapy in an extracted human tooth. Introduction. Pain control is an important aspect of the endodontic practice. The main cause of post-operative pain is trauma to the periapical tissue by mechanical, chemical, or microbiological origin, which leads to an inflammation known as flare-up. An innovative approach in managing postoperative pain is the use of intracanal cryotherapy. The method represents irrigation with solution cooled to 1 to 4 degrees Celsius and delivered to full working length as the final rinse of the root canals immediately before obturation. Purpose. The purpose of the present study is to investigate the in vitro method of intracanal cryotherapy and the factors influencing it. Material and methods. An extracted single-rooted tooth was standardized up to 15 millimeters root length divided in 3 zones. The root canal was shaped up to size 2508 with a one file. 3 final irrigation protocols with Endovac were applied. First, with a saline solution at room temperature 20 milliliters. Second, with a 2.5 degrees Celsius saline 5 milliliters, and third with a 2.5 degrees Celsius 17% EDTA 20 milliliters. The temperature on the apical and middle root zones were registered by 2 fixed thermocouples during the whole experiment. The room temperature was 23.3 degrees Celsius during all irrigation protocols. Results and discussion. For the middle third of the root surface, the lowest measured temperature during the control irrigation was 23.7 degrees Celsius, and for the apical third of the root surface, 23.1 degrees Celsius. Figure 1 represents control irrigation with saline at room temperature. First experimental irrigation with 5 milliliters, 2.5 degrees Celsius saline. The middle thermocouple recorded initial temperature 23.3 degrees Celsius, lowest temperature 13.3, and final temperature 21.2. The apical thermocouple recorded initial temperature 23.2, lowest temperature 10.1, and final temperature 20.7. The temperature was kept more than 10 degrees Celsius lower than the initial one only in the apical zone for 2 minutes. Figure 2 represents our first experiment. Second experimental irrigation with 20 milliliters, 2.5 degrees Celsius EDTA. The middle thermocouple recorded initial temperature 24 degrees Celsius, lowest temperature 13.1, and final temperature 14.3. The apical thermocouple recorded initial temperature 24, lowest temperature 10.4, and final temperature 11.3. The temperature was kept more than 10 degrees Celsius lower than the initial one for both thermocouples for 4 minutes. And figure 3 represents our second experiment with 20 milliliters, 2.5 degrees Celsius EDTA. The amount of the solution used for final irrigation varied from 5 milliliters, 10 milliliters, and 20 milliliters, as did the duration of the final irrigation from 1 minute up to 5 minutes. We established that 5 milliliters are not sufficient for keeping the temperature more than 10 degrees Celsius lower than the initial one for more than 2 minutes. To this moment, no in vitro experiment is known in which the temperature was measured in 2 points on the outer root surface using 2 thermocouples. In order to account for the difference in temperatures along the working length, we measured in 2 points using 2 thermocouples. In conclusion, first, cold irrigation should be conducted with more than 5 milliliters of cold irrigant and for more than 1 minute. Second, in an in vitro study, it is necessary to measure the temperature on the root surface in more than 1 point in order to measure the result of the cryotherapy. Third, it is necessary to measure the temperature of the irrigant within the syringe itself before starting the irrigation. Fourth, it is necessary to put the irrigant in one syringe and wrap it with ice during the irrigation. And thank you for your attention.
Okay, thank you very much to our student. This is Slava Georgieva, and you're welcome for questions. Very nice presentation. And maybe Associate Professor Dimitrova would like to say something.
I don't have a question.
Okay, if you have no questions, thank you very much. I would like to invite the next presenter, Ivan Damyanov, possibilities of 3D printing in the sphere of dental medicine. You're welcome.
Thank you very much, Professor Vakova. Okay, can you see my screen?
Yes, we can.
Okay, so today we're going to talk about the possibilities of 3D printing in the sphere of dental medicine. This presentation was prepared by me and Dr. Boschko from the Department of Prosthetic Dentistry. So what is 3D printing? 3D printing is a process of fabricating different constructions by utilizing additive manufacturing for which the object is constructed by layering the building materials. The integration of this technology in dental medicine is signified by the growing number of publications on this topic, which have drastically increased in the last 10 years, as you can see by the table on your right. The most published specialty was oral surgery, and the least published was periodontics. So let's talk about the types of 3D printers. We have selective laser sintering and stereolithography printers, which both utilize a laser, while selective laser sintering utilizes powder-based materials to form monolithic objects, layer by layer. Stereolithographers use a liquid resin base, which again will be polymerized by the laser. Next, we have fused deposition modeling. With this technique, a liquid material is delivered through a hot nozzle onto the printing bed, and after the construction of a single layer is finished, the printing bed or the nozzle itself will move a vertical step as signified by the arrows on the graphs. And I would like to mention that all of these graphs were prepared by me and Dr. Boschko. The PolyJet printers utilize the spraying or jetting of liquid photopolymers, which are then polymerized using UV light. And then we have bioprinters, which are used to make live matter constructions with the help of cell ink-based or microtissue-based inks, which then create different variants of tissues or different constructions which can be enriched with the use of different osteogenic factors or growth factors in order to be better accepted in the body. Then let's talk about the different applications in the different dental specialties. In the domain of, excuse me, can you still see my screen?
Yes.
Okay.
Yes, we can see.
Thank you very much. In maxillofacial and oral surgery, the introduction of three-dimensional imaging, such as the CT scan, has significantly improved diagnostics and planning of surgical interventions. As a result of the introduction of 3D printers, it is now feasible to use information attained through three-dimensional image diagnostic methods to fabricate patient-specific appliances. They can be separated in a few groups. Those are implant, surgical guides, prints, and contour models. On the image we have prepared, you can see a surgical guide for implants, which has been manufactured using a software and can later be printed and be much more precise and have better mechanical properties than the conventionally made subtractive guide. So additive manufacturing gives us the ability to utilize materials possessing a wide variety of physical and biological qualities. An example is the fabrication of a scaffold tailored to the patient's specifications, not only regarding the size and shape, but even the material from which it is made, making the end product more individualized by considering the required mechanical properties. And the success rate of the surgical placement of the scaffold can be improved by the incorporation of different factors and compounds. Then we have the 3D printed gingivectomy guide, which is an application of the 3D printer in the realm of periodontology. Well, in the realm of periodontology, much more research is still needed so we can be sure of the complete possibilities of 3D printing. But now, even those gingivectomy guides have drastically improved the quality of the procedure itself. In orthodontics, the exactitude and potential for customization of 3D printers can also be applied for the manufacturing of different aligners, which are devices to correct the smile of the patient. Next, we have 3D printed endodontic guides, which help us with the precision of the glide path we create during the endodontic treatment of molars or different root canals with complex anatomies. Next, let's talk about the education of dental students. As we all know, 3D printing presents us with extraordinary abilities for educating dental medical students, as well as doctors in training, even dental practitioners preparing for a complicated procedure. Due to the fact that its manufacturing can reproduce complex anatomical structures in great detail, at present, the training of dental students is done on idealistic plastic typodons. More often than not, these are unrealistic representations of a dental alveolar apparatus. By utilizing data from the CT examinations, we can create models as the one depicted, which include different abnormalities, thus preparing future doctors of dental medicine for the treatment of actual patients. And finally, I would like to say that 3D printing, although being a relatively new technological advancement, as it develops, it will find a more widespread role in our everyday practice as dental and medical care providers. It allows for a faster, more precise, and safer workflow. Although it is not yet a commonly used method, it has tremendous potential for the betterment of currently available dental procedures and training in dental medicine. This prospect of using stem cells and bioprinted scaffolds with the intention of planting a tooth germ in place of a missing tooth, or to regenerate tissue loss after a large trauma or radical surgical procedure can give all of us hope for a brighter future where healthcare will flourish hand in hand with science, advancing our quality of life substantially. Thank you for your attention.
Thank you very much. Dear colleagues, you're welcome for questions. Dear colleagues, do you have any questions? Okay, thank you very much to our student, Ivan Damianov, for the very nice presentation. And I would like to invite our student, first course, Ventsislava Pavlova. Please share the screen of your computer for the presentation, Aesthetic Prosthetic Rehabilitation by Digital Smile Design. You're welcome, Ventsislava. We can see the presentation, but we cannot hear you.
You have to turn on your microphone. The icon for that is at the bottom left corner in the Zoom menu. So please turn on your microphone.
Yes, the microphone is turned on, but we cannot hear. I see on the screen that her microphone is turned on. Okay, if you need little more time, we can continue with the next presentation and then to go back, or we wait another minute. Okay, try to switch on, to switch off and then to switch on again your microphone, Ventisława. Yes, we can see you, but we cannot hear you. Check if the microphone of the computer is being switched on. Okay, if you want to give more time to Ventisława and to go to the next presentation, at the last minute we have, okay, now we can see Ventisława on full screen. Okay, Ventisława, hello? Yes, we can see you, but we cannot hear you. Hello? Okay, Ventisława, can you try your microphone again? Okay, we'll give more time to Ventisława to check her microphone. And we'll go on the next presentation. At the last moment, the presenter changed. Clinical protocol for digital planning of single implants, a pilot study. The presenter was Viktor Hadjigayev, but he has some technical problems and he won't be able to connect. So I will present this presentation. Ventisława, we cannot hear you really. Okay, if you want, stop sharing the screen and check the microphone of your computer. If you want, leave Zoom and reconnect. And in the step where you have to join, they will ask you, do you want to use the computer audio? You have to switch it on. Maybe this was the problem. Okay, try to do it.
You can go on, Professor Vlachova. We try to assist.
Okay. So now I will share the screen of my computer. I'm sorry about this change, but something happened at the last moment. Can you see the screen of my computer?
Yes.
Yes, it's visible.
Okay, so this is one study that is funded by grant DPDP 6 2019. We have a scientific project with Dr. Pavlov as a main investigator, with Associate Professor Ivan Chenchev, with Dr. Viktor Hadjigayev, Dr. Stefan Zlatev, and we have assistance of Dr. Petya Kanazirska. from the Department of Radiology. The name of this project is Clinical Protocol for Digital Planning of Single Implants, and this is a pilot study. We just started this project October 1990. So the planning and positioning of dental implants, as you know, in an optimal site is very important for the durability and the trouble-free maintenance of the implant prosthetic restorations and the longevity of these restorations. The aim of this study is to present a protocol for digital planning and guided implantation of single implants in partially edentulous patients with single tooth missing and control method as well. So I switched on my camera to be able to see me. So the materials and methods, we used Trius intraoral scanner, computer tomograph, plan maker, 3Shape implant studio software for implant planning, 3D printer Formlabs, and CAM S2 impression milling machine, 5-axis VHF that we have in our CAD/CAM center. And in the software for implant planning, we aligned the data from the intraoral scans and the CBCTs, and according to the projection of the virtual crown that was generated inside the software, we made implant planning. Before the implantation, a temporary crown was fabricated by milling for immediate loading. And in the next slides, you'll be able to see step by step what was the protocol for implant planning, when the alignment between the data for the soft tissues and hard dental tissues was made. From the implant library inside the software, we made digital placement of the implant that is needed. In the individual case, you may see here in different planes the position of the implant. In the horizontal plane, you may see vestibulolingual cut. You may see also sagittal cut of the bone. Right after the implant planning, a surgical guide is being created, and the design was kept as STL file, and after that 3D printed. This is the 3D printer for resins and plastics in our CAD/CAM center, Formlabs of USA. This is the post-polymerization of the surgical guides and the design of crowns for immediate loading were made for all the patients till now. Till now, 20 patients were treated via this digital protocol, and 20 more are planned to be treated. We are using two implantological systems, AlphaBio and AB Dental, Israel companies, both of them. This is one PMMA crown for immediate loading with the titanium base. You may see here, this is the surgical guide toolkit of AlphaBio. We have another one of AB Dental with the special drills for implantation. This is the first one, tissue punch, because the procedure is flapless. It's very comfortable, very good for the patient, without elevating of a flap, without sutures, edema, and additional uncomfortable side effects. After that, all the drills were used through the surgical guide, and even the implantation was made through the surgical guide. You may see the opening of one implant and the placement of the implant through the surgical guide. And this is the step of immediate loading, the crown that is placed on the top of the implant right after the implantation. So a precise implant positioning was evaluated in most of the cases that we made till now. In most of the cases, it was possible immediate loading to be performed. In a few cases, when we evaluated not enough initial stability that was measured with special device Ostel with Ostel of WH company, we couldn't make immediate loading. Additional 39 patients will be treated. So the abstract was made for one patient only, but the reality is that right now half of the patients are already made. As I already told you, 20 of them are made, and we'll make 20 more. And at the end, we'll make statistics and summary of all the received results. So I would like to thanks to all the colleagues that participate in this project, to the directors of the CAD/CAM Center, Dr. Zlatev, and the director of the Implantological Center, Associate Professor Chenchev. And of course, I would like to thanks to Dr. Buyan Pavlov, who is the guide investigator of this project. I think at the end, this study will finish with one very good PhD thesis of Dr. Pavlov. The preliminary results of placing digitally planned single implants by guided surgery gives predictable results, and the idea is to create a full clinical protocol with both of the implantological systems, AlphaView and AB-Dental, that can be used in the future of our colleagues. Thank you very much for your attention. And if you have any questions, you can ask me, or you can ask Dr. Pavlov, who is also in the meeting. Okay, dear colleagues, thank you very much. Now, again, to invite our student Ventsislava Pavlova to try to share the screen of her computer.
I think we can probably give time to Ventsislava to reconnect again, and maybe we can continue with the next one due to the problem.
Okay, we'll continue with Dr. Ioana Georgieva. You're welcome. Standard deviation of students' preparation of phantom premolars. Dr. Georgieva, you're welcome. I think Dr. Georgieva also has some problems. Okay, let's continue with Dr. Maria Christosova, and then we'll go back to Ventsislava Pavlova and to Ioana Georgieva. Dr. Christosova, you're welcome.
Thank you, Professor Vlahova. I'm sharing my screen. Is it visible?
It's okay, but we hear you a bit low, so please speak louder.
Okay. So this work represents a full digital approach in aesthetic rehabilitation. Our patient was a 61-year-old woman with anesthetic concerns in her visible dentition. There was a metal ceramic restoration, fixed partial denture with unpleasant appearance. The adjacent teeth were with severe incisal abrasion and disproportional crown length. It's visible, even more obvious on the conventional models. The idea was to work the total procedure only digitally. So for this purpose, we were supposed to achieve digital formats of the images of the patient. For this, we used facial scanner Bell's 3D Face Camera Pro to obtain the facial scan of the patient. And we used the dental laboratory 3D scanner to obtain the digital image of the upper and lower jaw of the patient. The idea is to develop a virtual patient. For this purpose, the both data that we acquired from the laboratory scanner and the facial scanner were superimposed in Dental Designer Studio by 3-point alignment. And after this, digital wax app was designed. The difference here in the digital manner is that we are using the patient's facial anatomy as a leading guide. So the design is done under the leading guides of the facial and the intraoral structures. Here it's visible some of the instruments that we use and the way we are taking in mind the anatomical features of the patient's face while we are doing the digital wax up. Here again are some images of the procedure of the digital design, the artificial crowns from the library and the instruments that we use to achieve the final design. After the digital design, we are supposed to produce and to transmit the digital design and to materialize it in real model. So it was printed. The printed model was used to produce vacuum-formed matrix, and with the help of these matrix, the motivational mock-up was transferred into the patient's mouth for functional and aesthetic evaluation. It was used for guiding of the crown lengthening by electrosurgery. After the aesthetic approval of the proposed design, minimally invasive tooth preparation was performed under the mock-up guidance, and provisionals were produced. The aesthetic result of the provisionals is visible on the pictures that are uploaded. And after this, the materialization of the proposed treatment should be done. For this purpose, we obtain new intraoral scanners from the patient. After the preparations of the teeth, 3D models were printed. The prosthesis prototypes were printed from castable wax with Formlab forms. and the final restorations, which were 3 veneers and 1 bridge, were fabricated from lithium disilicate ceramic, IPS Empress, and were luted with Variolink aesthetic double cure material. And of course, the final restoration shows that the aesthetic reconstructions produced in this manner, guided by the facial and intraoral anatomical features, are really well accepted, good fitting to the patient's face, not only to the intraoral structures. And you could see the result before and after this. Thank you.
Thank you very much, Dr. Christosova, for the nice presentation. And I would like to give you ability to ask her questions. Dear colleagues, do you have any questions for Dr. Christosova? So, as you already understood, the digital dentistry, it's not the future, it is the reality. And I would like to congratulate Dr. Christosova for the digital protocol that she's working with. And I would like to see her working according to a scientific project in this field and to make a PhD thesis in this field soon. I wish you luck, Dr. Christosova.
Thank you.
And I don't know what's going on with Ventsislava Pavlova. Did you succeed to switch on your microphone or you need more time? Would you like to start? No, I cannot see her here. Maybe she's disconnected at this moment. So we'll continue with the next one in the timetable. Konstantin Trifonov with the presentation horizontal ridge augmentation in the anterior mandibular region using the sausage technique, a case report. You're welcome.
Hello to all of you. Today I'll present a case. Just to share my screen, 1 second. Can you see my screen?
Yes, we can see.
Okay, today I will present a case that was done by me and Dr. Girov. We both are specializing oral surgery in the oral surgery department. It's a case of horizontal ridge augmentation in the anterior mandibular region using the sausage technique. So our patient is a female. She is 62 years old. She has no general diseases. She's taking no medication, but she is a smoker. As you can see, the clinical view of the patient, the diagnosis is Adentia partialis mandibulae in regio 3.2 to 4.2. And we've got the typical knife edge vestibular resorption of the bone. And of course, not a proper amount of horizontal width of the bone. In this slide, you can see the CBCTs of the patient. The plan is to insert 2 implants, 1 left and 1 right. And as you can see, the width of the alveolar process at the crest is close to 3 millimeters, quite insufficient for proper placement of implants, even 3 millimeter implants. The treatment plan is initial therapy, disease controlled phase. Phase 2 is surgical therapy. Stage 1, horizontal ridge augmentation, sausage technique. Stage 2 is implant placement after 6 to 9 months. And stage 3 of the surgical therapy is soft tissue augmentation. And then we've got restorative therapy and maintenance phase. So the plan is to create a flap that is actually vestibular and lingual flap. The vestibular flap is distal to the first premolars, whereas the lingual flap, the vertical incisions, are distal to the canines. Sorry, one moment. On the lower left picture, you can see the vestibular flap elevated, and on the lower right picture, you can see the perforations of the cortical layer of the vestibular bone. On the upper left corner, you can see the big collagen membrane that was trimmed to the proper shape. And on the upper right picture, you can see the big PRF membrane that we created by using 3 small APRF membranes that were sealed together with IPRF. On the lower left corner, you can see the bovine bone, xenogenic bovine bone by BIOS, and the autogenous bone that we harvested from the patient. On the lower right corner, you can see the creation of sticky bone by using bovine bone and autogenous bone and IPRF. Next stage is fixation of the membrane. First, we fixated the membranes by 2 titanium pins lingually, medial to the canines. The second stage is positioning to the sticky bone. On the lower left corner, you can see the fixation of the membrane. The fixation of the membrane. The lower right corner, you can see the PRF membrane. Then we go to suturing. 2-layer suturing was used in this case. We used matrix sutures that were like half to 1 centimeter away from the incision line. And on top of this, we placed single interrupted sutures to close the incision line. And you can see pictures of the suturing. This is 2 weeks post-surgically. As you can see, there is a small dehiscence at the 3-3 area. This is the dehiscence of the lingual flap because it's not so vascularized compared to the vestibular flap. This is the post result. Sorry, one moment. This is the post result. So on the left, we've got gain of 6 millimeters, and on the right, we've got gain of 5.44 millimeters of horizontal ridge augmentation. And the final result with the implant in place and CBCT of the area. Thank you for your attention.
Thank you very much for the nice presentation. Do you have any questions for Dr. Konstantin Trifonov? You're welcome. Dr. Trifonov is waiting for your questions, if you have such. If no, we'll continue with the next presenter, Dr. Maria Shindova from the Department of Children Dental Medicine. You're welcome. Alternative methods for caries removal.
Can you see my screen?
Yes, we can, and we can hear you.
Thank you. Today I will present for you a brief review of the alternative methods that are used for caries removal in pediatric dentistry. First of all, it is necessary to make a differentiation between the 2 types of caries dentin that can be found in the caries lesion. As you can see on the picture, the superficial layer, which is called infected dentin, is soft yellowish to brown layer, which can be deformed by pressing an instrument into it and easily removed by gentle scraping. This layer requires removal because of the irreversible destruction of the collagen fibers, lack of mineral content, and the high bacterial concentrations, and it is unable to undergo remineralization. In contrast to it, the deeper layer called affected dentin is firmer and light brown in color than the infected one, described as leather-like, and there is no deformation when an instrument is placed into it. It can be scraped off, but with medium pressure, and it is preserved during caries removal. This layer is preserved due to the collagen network, which is present and preserved due to have some mineral content and due to the fact that there is no bacteria here. That's why this layer has a potential for remineralization. The most common alternative methods that are used in pediatric dentistry are the polymer burrs, air abrasion, ultrasonic excavators, or traumatic restorative treatment, chemomechanical excavation, lasers, and ozone therapy. The basic requirements to these methods include the selective removal of the infected dentin only, the method to be reliable and effective, painless and silent, causing minimal pressure during excavation and no vibration and heat generation, and of course to be convenient and easy to use in the dental office. First, the polymer burrs are round burrs made of ceramics. Their advantages include the fact that they ensure selective removal only of the infected dentin because the material hardness doesn't allow an excessive preparation. Once all soft carious dentin has been removed, the instruments automatically blunt into the hard, healthy dentin. When compared to the diamond and steel burrs, the polymer burrs remove the dental tissue selectively, but it required 2 to 3 times longer for caries removal procedure. The disadvantages include the single use and sensitivity of the technique. And when there is an application of high pressure, there is an excessive excavation of healthy dentin. The burr breaks when it comes into direct contact with the enamel, and usually they're used in combination with steel or diamond burrs when they're used in the enamel. The second method is air abrasion. It is a pseudo-mechanical, non-rotary method of cutting and removing hard dental tissue, ensures selective removal by a fine stream of aluminum oxide particles generated from compressed air until it reaches hard and dry dentin, as well as preserving the healthy tissues and those that can undergo a remineralization. The efficiency depends on the hardness of the material of the tissue as well as the operating parameters. Special nozzles provide exceptional accuracy of particle stream as well as low air pressure. An adequate suction is obligatory required. The ultrasonic caries removal system usually is a combined device, most commonly Pearson Master 600. It has different coated diamond tips. It ensures selective removal only of the infected carious dentin, preserving the healthy enamel. It ensures low vibrations and mechanical trauma and elimination of the unpleasant sound of the air tube in. When there is an unilateral use of the diamond-coated tip, preservation of the healthy enamel of the adjacent tooth is reached. The automatic restorative treatment is part of the AAT technique used in pediatric dentistry. Here, soft part of the carious lesion is removed manually using a special set of heavy instruments called excavators, which remove only the infected dentin until reaching firmer and light brown in color the affected one. It can be combined with a chemical agent which dissolves the carious dentin, and in this way, it is easier to remove it with a hand instrument. It ensures self-control during the process of excavation due to the fact that there is a manual tactile sensation of the operator. Chemomechanical carious removal is another method which includes treatment and application of a chemical agent in the carious lesion before the carious removal. As a result of that, changes in its structure and composition occur. And this results in more simple, fast, and selective process of carious excavation. This method is a combination between use of set of heavy instruments, excavators, and agents that can be inorganic, for example, sodium hypochlorite and product is Kerisol, or another agents, organic enzymes, for example, Brix 3000 with the enzyme papain, of collagenase, pronase, pepsin enzyme also can be used. Lasers are another alternative method most commonly used in pediatric dentistry that are used for ablation of hard dental tissues. Usually we use high power lasers, the family of erbium lasers, which are two types, erbium YAG and erbium chromium YSGG lasers, but the main mechanism of the action includes thermomechanical ablation. The most important is the main principle in laser treatment to select proper parameters for maximal effect in ablation and minimal side effects. We must be very precise because parameters are different for laser ablation in enamel, dentin, primary, permanent teeth as well. And the last one method is ozone therapy, which uses a gas with a characteristic penetrating odor. It kills microorganisms penetrated into the dentinal tubules, and usually the ozone therapy is used for cavity disinfection. The device produced by Cavadental is called HealOzone and have 5 sizes of silicone cups in order to ensure a good fit and secure seal over the teeth of different shapes and size. The exposure is between 10 to 40 seconds and the treatment continues between 2 to 3 minutes, followed by a professionally applied remineralizing solution. These are briefly summary of the methods. Thank you for your attention.
Thank you very much, Dr. Shindova, for the nice presentation. I would like to give ability of the other participants to ask you questions. Dear colleagues, do you have any questions or any comments for the presentation and the study of Dr. Shindova? Okay, thank you very much, Dr. Shindova. The next presenter in our program is Zlatizara Todorova, subepithelial connective tissue graft in the plasty of gingival recession. You're welcome.
Hello, dear colleagues. Can you hear me?
Yes, we can hear you.
Okay. I will present to you a clinical case of a 30-year-old female patient, not medically compromised, whose chief complaints were aesthetic disturbances associated with root exposure of upper right canine. Medical history showed previously provided orthodontic treatment as well as traumatic toothbrushing and sensitivity to cold drinks. On intraoral examination was revealed a single maxillary canine gingival recession classified as Miller's class 2. You can see it on the first photo. Based on these findings, a surgical protocol was made that included first, recipient site preparation with horizontal incision at the level of the cemento-enamel junction, followed by vertical incisions on both sides to the alveolar mucosa and partial flap reflection. You can see that part on photo 2. All that was done under local anesthesia. Then, from the palatal aspect of the second premolar and first molar, were made first a horizontal incision 3 to 4 millimeters apically to the pregingival margin, and secondly, a vertical incision medially to it. After exposure of subepithelial connective tissue, the graft was harvested with a blade. This you can see on photo number 3. The root surface was polished and tetracycline solution was placed over it, followed by suturing the graft and placing the partial thickness flap in its initially anatomical position, which is seen on the 4th photo. On photo 5, you can see the recipient site after removing the suturing material 2 weeks later. 6 months later, the clinical examination of the patient showed 80% root coverage. In conclusion, the treatment approach with a subepithelial connective tissue graft proved to be a successful technique of treatment for achieving significant root coverage, clinical attachment, and keratinized tissue gain. That's all, dear colleagues. Thank you for your attention. Now, if you have any questions, Dr. Tsvetanov and I are here to answer them.
Okay, we can give the word to Dr. Tsvetanov to say something also.
Dear Professor Vakova, I have no questions.
No, I didn't mean questions. I mean a comment, because this is a common work.
Yeah. It's a common work. Yeah, we provide treatment of the single gingival recession around the canine on the right side of the maxilla. And we cover the recession by usage of the subepithelial connective tissue graft take from hard palate surface. Any questions about the case?
Okay, dear colleagues, you have the ability to ask questions. I would like to ask how long was the healing period, Dr. Tsvetanov?
We provide control examination 6 months later, and we observe 80% root coverage of the recession.
Okay, and it will be permanent for how long, or you cannot you cannot tell how long will be the effect?
Yeah, not possible. After 1 year, we provide again control examination to assess quality of the tissue, especially quality of the or quantity of the attached gingiva.
Okay, very interesting. And what was the etiology? What was the etiological factor for this recession?
The etiological factors may be according to the medical history, previous provided orthodontic treatment or traumatic tooth brushing.
Okay, thank you. It's really interesting, and that's why we have to advise our patients when they're brushing their teeth not to use horizontal movements, mainly vertical and circle movements, because some of them they are really strict in the oral hygiene, but if they use a big pressure, they can cause a gingival recession and also cervical defects. Okay, so if you have no other questions, I would like to give the word to the next presenter. I just saw in the chat that the next presenter won't be Desislava Petkova. It will be Jordan Todorov, student from 6th course, and the topic is non-surgical clinical management of periapical lesions using long-term calcium hydroxide paste, a report of several cases. Okay, we can see the screen of the computer, but we cannot hear. Okay, you can switch on your microphone to be able to hear you.
Can you hear me?
Yes, now we can. You're welcome.
Hello everyone, my name is Suzanne Wolf. I'm a 6th-year dental student in Faculty of Dental Medicine in Plovdiv, and I present you a report on surgical management bariatric lesions using long-term calcium hydroxide dressing paste. The aim of our study is to present cases in which calcium hydroxide was used.
Excuse me, but I cannot hear you very good. If you can make your microphone louder or to change something, because I really cannot hear you very good.
Okay, just a second. And now? Thank you.
It would be useful to speak closer to the microphone, and to avoid microphonia, you could turn off or really turn down the volume if you're using a laptop. I mean, the volume of the speaker,
Okay,
so that we get the sound from the microphone.
Do you hear me now?
Yeah, now it's better.
Okay, I'll start from the beginning. The aim was to present cases in which calcium hydroxide was used as an intracanal medicament for long-term treatment to treat the persistent chronic bariatric lesions, aiming to avoid further surgical interventions. 4 clinical cases diagnosed with chronic atypical periodontitis were treated with long-term calcium hydroxide dressing for a period of 3 months. All of the patients had radiographic evidence of atypical periodontitis and previous endodontic treatment performed. The applied treatment protocol was one and the same for all patients. After obtaining patency, canals were instrumented to a minimum size of 3007 paper. Final irrigation of 2.5% of sodium hypochlorite and 70% PDTA solution was agitated with basic ultrasonic irrigation. After drying the canals with paper points, the canals were temporarily obturated with extempore prepared calcium hydroxide paste by mixing calcium hydroxide powder with distillated water. Calcium hydroxide paste was loaded in the canals and refreshed 3 times for a period of 30 days. After 1 month, the root canal dressing was removed, and all canals were filled with glutathione and bioceramic sealer. Control X-rays were taken immediately after the effective operation of the root canals and 12 months later. The non-surgical approach was dictated by the high rates of complete or partial healing after non-surgical endodontic therapy of approximately 90%. Surgical methods have many disadvantages, so they are considered exceptionally of the non-surgical technique that failed to show signs of healing. In addition to mechanical equipment and antibacterial irrigation, use of calcium hydroxide as intracanal medicament has been shown to reduce the bacterial count further by 80 to 100%. This has been the basis of the multi-visit treatment of atypical periodontitis. And even though modern endodontic state that cleaning and shaping have greater importance than intracanal dressing for the success rate of endodontic treatment, intracanal medicaments are still used when more than 1 point is needed for the root canal treatment, and most likely it is in the presence of a large bariatric granuloma or cyst. Although periapical bone healing for smaller lesions can take up to 6 months, and large periapical lesions require 9 to 12 months for complete bone regeneration around the apical region, as the average healing rate is about 3 square millimeters per month. The intracanal medicament for extensive bone destroying lesions should be placed for at least 1 to 2 months and refreshed once every few weeks according to Dixit-et-al. Control X-rays for assessment of the healing process were made after 12 months. During this period, the teeth didn't show any clinical symptoms. Calcium hydroxide enhanced the healing of periapical lesions in the reported cases. The less invasive procedure avoided possible following endodontic surgery and reduced bone resorption. We find it more predictable to complete treatment of chronic periapical lesions with long-term calcium hydroxide dressing. The efficient chemical-mechanical treatment and calcium hydroxide-based intracameral medicaments are the steps that can assure a satisfactory outcome of extensive bone destroying bone lesions. This is for all. Thank you for attention. If you have some questions.
Okay, thank you.
She can respond to your questions.
Okay, yes, Dr. Markova is online also. Maybe she can make some comments because this is a common work.
Hi, dear colleagues. This is Dr. Popova speaking. We have to make the hard decision to retrieve this teeth or to extract them actually. And we think that the long-term calcium hydroxide dressing gave us a chance to obtain a good healing and to keep this teeth. If you have any questions.
Okay, dear colleagues, do you have any questions? Okay, if you have no questions, I can see that Ventislava Pavlova is online again. I understood that she changed the computer and will try with a new one. Okay, Ventislava, you're welcome. Please share the screen of your computer and switch on your microphone, please.
Hello again, can you hear me?
Yes, now we can hear you.
Oh, I'm very happy to hear it.
Okay.
So my presentation is about aesthetic prosthetic rehabilitation by using digital smile design. Aesthetic prosthetic treatment is a part of the rehabilitation of the masticatory system. The visualization of the planned final result in advance is the beginning of the clinical protocol. The prepared prognostic result by the treatment team has to be approved by the patient. Classically, the visualization is made by workup on plaster models. It could be followed by mock-up with temporary material on natural teeth. Entering the new digital technologies, all this can happen virtually. The aim of the study is to present a protocol for making temporary and definite fixed prostheses by digital planning and 3D printing. For the aim of this study, TRIOS intraoral scanner and Canon camera were used. This software for planning was TRIOS Smile Design. This software allows planning and visualizing of the final result of prognostic treatment in the aesthetic zone. This was made by superimposing of 2D picture of the patient and 3D intraoral scans. The final result information was sent to the dental laboratory. In the lab, a prognostic workup was done and made as printed model. The planned temporaries could be made by milling or printing. The procedure started with intraoral scanning. Using TRIOS intraoral scanner, the initial situation of the upper and lower dental arches were scanned. Digital bite registrations were taken too. Next, photo pictures of the patient face with and without wide smile retractors were made with professional photo camera. Both data from the intraoral scanner and the camera were imported in the TRIOS software with activated option for 2D smile design. The images were aligned via anthropometric points. In the next step, different tooth shapes and sizes from the virtual library were tried. We offered to the patient 2D design of her smile with oval, triangular, rectangular, and square shape of teeth with different sizes. Discussing the options, triangle shape for the teeth was chosen. This shape matched the face of the patient. Finishing the smile design, the patient could see how she would look like at the end of the treatment and the dental team understand the patient expectations. According to the 2D Smile design in the dental office, 3D digital workshop was made in Dental Designer 3Shape Denmark laboratory software, and it was 3D printed on models. The clinical work started with removal of the old upper restorations and fabrication of direct prognostic mock-up with composite material structure, Volkov, Germany. Some of the teeth needed to be built up. The crowns of the preserved abutment teeth were prepared and finished, and the damaged teeth were restored with digital post and core restorations. An optical impression was taken from the upper arch with post and core scan bodies and was sent to the laboratory. According to the approved tool design, the dental technician made the metal post and core restorations and 3D printed composite provisional bridge restorations. On the next clinical visit, the post and core and the upper provisional bridge restorations were fixed, so the patient received her new upper teeth made upon the virtual plan. She was with the temporaries for a few weeks and no complaints were reported in this period. After that, the final digital impressions for the upper permanent restorations were taken. The treatment of the upper arch was accomplished with metal ceramic bridges with the same design. The lower arch was proceeded in the same succession. The difference between the two arches was the presence of 4 implants in the distal areas of the lower jaw. The implant position was digitally scanned with scan bodies fixed to the implants. The final metal ceramic bridge restorations are waiting to be fabricated in the dental lab. Classically, the visualization of the result of the prosthetic treatment is made by analog workshop on plaster models. It could be followed by mock-up with temporary material on natural teeth. Entering the new digital technologies, today all this can be made virtually. Digital smile design, 3D printing, and milling together provide an excellent alternative to the classical analog protocol. 2D digital smile design ensured predictability of the prosthetic treatment. Highly aesthetic direct and indirect temporaries were made according to the digital workshop. From the beginning, the dental team knew the expectations of the patient, and both the patient and the team were prepared for a desired result of the aesthetic prosthetic treatment. To sum up, digital smile design gives many possibilities for aesthetic rehabilitations. The virtual planning and machine manufacturing of the temporaries save much time of the team and the patient as well. Thank you very much for your attention.
Okay, Vencislava, thank you very much for the nice presentation. Do you have any questions or comments for the presentation of Vencislava Pavlova? I would like to make a comment that you saw that the clinical case is still not finished. We are waiting the lower metal ceramic restorations to be fabricated in the dental lab. At the beginning of the next week, they will be ready. I hope everything will be okay and we'll be able to fix them in the patient mouth. That's why the clinical case is still not finished. But the digital smile design gives really a good predictability of the final result, and everything is predictable, and we know from the beginning what will happen at the end. The patient also, the dentist, the dental technician, and it's really good option to make the prosthetic treatment. Okay, thank you very much. to Ventsislava Pavlova. If you have no questions, let's continue with the next e-poster that will be presented of Dr. Tsvetan Tsvetanov, plasma levels of buffered artiquine and metabolite artiquine acid compared with non-buffered versus. We already can see it on the screen.
We cannot hear you. Please put your presentation on full screen and unmute your microphone, and you're welcome.
Dear Chairman, dear Organization Committee, dear Professor Vlahova, I will present the topic of poster. It is part of our scientific project. The topic is plasma levels of buffered articaine and metabolite articaine acid compared with non-buffered analog. The buffered anesthetic have potential advantages. When we added sodium bicarbonate, 8.4 solution, we achieve decreasing pain during administration of the anesthetics. Also, the buffered anesthetics is possible to work in case of inflammation process, because in case of inflammatory process, we have low pH of the tissues. With the buffered, we increase pH. The most commonly local anesthetics in dentistry have pH approximately between 3.5, 5.5. When we added sodium bicarbonate, we increase pH up to 7.4. Other advantages of the conventionally buffered method is to increase absorption of the anesthetics. This led to the fast elimination from the body. With buffered, we decrease toxicity of the anesthetics. The purpose of our investigation was to confirm or to reject the working hypothesis, mean blood level difference of 4% articaine with 1 per 100,000 epinephrine for each patient are significantly lower after mandibular nerve block with the buffered agent compared with non-buffered analog. It is according to the literature date. Our study was involved 39 patients, males and females. The age varied between 22 and 78. The median age was 47, while the median body weight was 81 kilogram. We count the kilogram because one carpule consists of 68 milligrams of active anesthetics. Venous blood samples were drawn from for the measurement. We drawn the blood from the antecubital fossa 5 minutes after the administration of the anesthetic solution, buffered or non-buffered, because according to the literature dates, the maximum peak plasma concentration are achieved 10 minutes after administration. It is of the anesthetic articaine, but according to the science articles of the main metabolites articainic acid, the peak plasma levels are achieved 45 minutes after administration. We assess the plasma levels usage of the analytical column by liquid chromatography tandem mass spectrometry methods. It is visible mean blood buffered articaine plasma levels. We count in the milligram per liter. For the buffered anesthetics are 0.28 milligram per liter, but for the non-buffered 0.37 milligram per liter. Also, we count the plasma levels of the main metabolite, articainic acid. For the buffered anesthetic, 0.09, milligram per liter, and for the non-buffered 0.38 milligram per liter. The difference between patient preference for the buffered or non-buffered articaine wasn't statistically significant. We didn't determine statistically significant difference. We concluded that our preliminary working hypothesis was not confirmed by mean plasma levels of the buffered and non-buffered anesthetics, especially acknowledgement to the National Science Fund for the financial support. I want to especially to thanks for the Dr. Desislav Tomov from the Department of Organic Chemistry, Faculty of Pharmacy, for the method support. Thank you for your attention.
Thank you very much, Dr. Tsvetanov. Do you want to make some comments, to ask some questions?
It is part of my scientific projects. Our purpose is to provide subjective measurement of the pain during administration and to compare buffered and non-buffered anesthetics. Also, we measure the duration time of anesthesia when we use buffered and non-buffered anesthetics, and to provide by the liquid chromatography, mass spectrometry, objective measurements of the plasma levels. And our investigation will continue. It's our purpose because we need from more patients.
Okay, thank you. I can see Desislav Tomov also in the meeting, so maybe he would like to make some comment. Okay, if there are no comments, no questions, I'd like to give the word to Associate Professor Dimitrova, because according to my timetable, the English-speaking presentations finished, and we have Bulgarian one.
Здравейте, колеги, от мен. Предстои да дам думата на нашия единствен участник в тази сесия на български език, Лиляна Щерева, която ще ни представи ефективност на приложението на Силан на гласиономерна основа върху първи постоянни молари в пробив, които са резултати от тяхно 6-месечно клинично проучване. Имате думата, Лиляна Щерева.
Благодаря. Надявам се да виждате екрана.
Да, вижда се.
Добре. Ще ви представя темата ефективност на приложението на Силант на гласиономерна основа. Приложили сме го върху първи постоянни молари в пробив. Силанта е частично покритие, профилактично, което се аплицира върху ямки и фисури с цел да се предотврати развитието на кариеса. И съответно първият такъв успешен Силант още през 1955 година е успял да бъде поставен от Болнокър и от тогава са правени редица опити, провеждани са опити с различни материали, като съвременните материали всъщност стигат до силанти на композитна и силанти на гласиономерна основа. Именно един от тях сме използвали в настоящото клинично проучване, тъй като голяма част от авторите смятат, че частичната загуба на силант увеличава риска от появата на кариес. Това ни мотивира да проведем и проучването. Целта е да проследим ретентивността и кариес профилактичния ефект на силант на гласиономерна основа след силанизиране на първи постоянни молари в пробив на деца от 5-6 годишна възраст, като проучването стартирахме с 78 здрави първи постоянни молари в пробив. Силанта, който избрахме, беше на Фуджи триаж на GC, като проследихме пациентите на 3 и 6 месеца. Методите за проследяване, които използвахме, беше визуален метод на диагностика по системата ICDS-2. Отново използвахме същата система, но чрез диагностика под увеличение с помощта на VistaCam макро и също така модифицирани рич критерии за ретентивността и кариес профилактичният ефект. Прекодирахме последствие данните, в зависимост от степен на задържане на силанта и наличието на здрава или кариозна повърхност, след което проведохме и честотен анализ. На снимките тук вдясно можете да видите всъщност без и с увеличение първи постоянен молар преди и след поставянето на силанта Fuji Triage Pink. Съответно, на диаграмите пък можете да проследите това, което получихме като резултат относно кариес профилактичния ефект на силантите, в зависимост от трите метода, които използвахме, като визуалната диагностика определи 100% от силанизираните първоначално повърхности за здрави. Минимално количество кариес откриха рич критериите, както и при преглед под увеличение с помощта на VistaCam макро едва 2,9%. Останалите 97% бяха определени като здрави. По-различно стоят нещата с ретентивността на силанта, тъй като според визуалната диагностика и рич критериите, цялостен силант на 6 месец открихме едва при 22% от силанизираните повърхности, а пък частичен такъв при 61,2%. След поглед под увеличение установихме, че е доста по-голям процента на частично запазения силант, а именно над 80% от случаите силанта беше частично запазен и само в 11% цялостен. Съответно, нашето заключение беше, че силантите на гласиномерна основа са основно средство за превенция на кариес при новопробили първи постоянни молари, когато не е възможен перфектен контрол на средата и не е възможна перфектната изолация. Въпреки по-слабата му ретентивност, неговия кариес профилактичен ефект е отличен. Благодаря за вниманието.
Благодаря. Това, което бих искала аз да кажа, защото аз също много използвам този материал и знаем неговите предимства, които са свързани именно с възможността му да се задържа върху такива зони, където е невъзможно да осигурим сухота на оперативното поле, така че може би тези резултати са напълно обясними, които получавате, но пък от друга страна те са достатъчно обнадеждаващи за неговия успех като средство именно в такива случаи. Доцент Кондева, дали има да каже нещичко по този въпрос, защото виждам, че и тя също е част от екипа и от нашата сесия.
Аз исках да взема последно думата и да поздравя всички участници в тази научна сесия, нашите колеги, нашите студенти, да поздравя и вас, заедно с професор Влахова, за перфектната организация относно провеждането на сесията дентална медицина и да поздравя всички за празника, който имаме, професионалния ни празник, като пожелая на всички много здраве, много успехи. Що се касае до темата, да, действително, тя е част от едно по-голямо проучване и резултатите посочват изключително добрите качества на гласиономера и то точно този, който ние изследваме за успеха и доброто задържане, добрата ретентивност и добрия кариес профилактичен ефект. Това е, което мога да кажа относно темата. Поздравления на всички колеги за прекрасните презентации, за добрите теми, които ни представиха на днешната сесия. Благодаря.
Благодаря, доцент Кондева. Аз също бих искала да кажа няколко думи, въпреки моето така скромно участие в днешната сесия. Първо бих искала да благодаря на ръководството на Медицинския университет и на Факултет по дентална медицина за наистина добрата организация. Бих искала да кажа едно огромно благодаря на всички вас като участници за добрите презентации, на вашите екипи, за добрата екипна работа, за добрата колаборация колаборация между различните звена в нашия медицински университет. Да казвам звена, защото това са катедри, високотехнологични центрове в нашия факултет и не на последно място за добрата колаборация между преподаватели и студенти, защото виждаме един изключителен интерес от страна на студентите, за което благодаря. Разбира се, благодарности и към всички преподаватели, които са положили немалки усилия, за да интегрират нашите студенти не само в преподавателската дейност, но и в научната дейност. От мен желая ви всичко най-добро в днешния ден и във вашата бъдеща работа. Повечето от вас виждам, че са представили фрагменти от свои научни проекти. Всичко най-добро, колеги. Професор Влахова.
Здравейте и от мен отново, този път на български. Изключително доволна съм от научната сесия. Благодаря на всички за стегнатото представяне, за добрата организация, за хубавите презентации и електронни постери. Като част от екипа на CAD/CAM центъра на факултета по дентална медицина съм изключително доволна, че половината от разработките са направени именно в CAD/CAM център и с участието на CAD/CAM центъра по дентална медицина. Виждам, че имаме още няколко минутки и за това ще дам думата и на доктор Златев, който е ръководител на CAD/CAM центъра, и той да каже няколко думи, тъй като и двамата сме наистина много доволни от активното участие на центъра в разработките, които бяха направени. Доктор Златев, ще кажете ли нещо?
Здравейте, колеги! Аз искам да поздравя всички, особено студентите, за прекрасно изнесените презентации и за работата, която са положили. Радваме това, че сте ориентирани към дигиталната дентална медицина, защото знаете, че в съвсем скоро време, дори за някой от вас, първа при завършване, това вече ще бъде, как да го кажа, една такава дисциплина, която ще е превърната в основна в нашата професия, особено що се касае до протетичната дентална медицина, където, знаете, индиректните конструкции се произвеждат вече в голям процент от случаите в световен мащаб дигитално. В Щатите, които са първа икономическа сила, в момента последните данни сочат, че около 70% от произведените индиректни конструкции са именно с някакво участие на дигитализация, което само по себе си говори, че целият останал свят рано или късно ще догонва тези цифри, които ще се увеличават. Още веднъж благодаря на ръководството и на Организационния комитет, както и на вас, професор Влахова, и на доцент Димитрова за участието ви и така пожелавам ви прекрасен слънчев ден.
Благодарим, доктор Златев. Аз пък искам да благодаря на доктор Петър Димов и на целия организационен комитет на Младежкото научно дружество Асклепий за организацията, за поканата да бъдем модератори и участници в научната сесия. Благодарим на студентите, на докторантите, на асистентите и всички преподаватели за ентусиазма, с който за поредна година се включваме и участваме в научната сесия. Искам да пожелая на всички отново честит празник и един хубав неделен следобед на всички. Благодаря ви, бъдете здрави!
Благодаря и аз на всички. Поздравления и от мен за професионалния празник на лекарите по дентална медицина. Мисля, че чудесно протече конференцията, сесията и много благодаря и за работата на модераторите. Много стройно беше всичко и така хората бяха почти перфектно подготвени. Сега винаги има някакви дребни технически неща, но мисля, че много добре се справихме с всичко. И всъщност сме готови да закрием тази сесия. Според програмата ни остава още една, която стартира в 2:10. Това е последната сесия за конференцията, след която ще закрием, която е посветена на социалната медицина и общественото здраве. Така че сега излизаме в почивка и до след малко.